everybody.
Hi, Amy. This is John Stenzel. Adelina, I may not stay the whole time because I think I could talk about your program too.
You could. I love seeing you. Thanks for joining, John.
Absolutely.
And I won't know if you're gone or not because I'm only going to be able to see my own screen.
Well,
so
Amy's going to check my absenteeism, I'm sure.
That's right. I take notes.
Okay, awesome. Let's see then. Let me get back on here. All right. Well, should I get started, or are you think we're waiting on a couple more people? I know you said people are coming in and out.
Yeah, they're coming in and out. So let's go ahead and get started. But I'll start just by introducing everyone to Adelina Brisebois from Engage Treatment Center. And they work with our teenage population. I'm super excited about working with them. They just came into our marketplace recently. And also, congratulations to Adelina. She is a new mom with a little cute, adorable little baby.
Thank you. Thank you. Yeah, so we are really thrilled to be part of this group. Just Amy, the work that you've done and getting people connected that is why my husband and I do the work that we do. So we're really excited to share a little bit more, and please interrupt me. Again, I can't see any of you. So wait, is it sound okay or is it echoing?
It's you signed in twice. So you are, there we go. Can we still hear you? Let's see.
I stopped sharing my screen. Let me see if that's
that you're not echoing anymore, so that's good.
Okay. You know what I'm going to do? I'm just going to talk to you guys. What I have to show by visual is not what's important. It's the work that we do. So I'm just going to speak with you, if that's okay. There's some pretty pictures, and that's about it. So what I was saying is, so yeah, my husband and I, we're both clinicians, and we own and operate Engage. We're an intensive outpatient program here in Westlake Village. We focus on primary mental health, so depression and anxiety is what we treat, and we work with youth. So we have programs for ages 10 all the way to 25, but we actually have 3 different programs within our program that's separated by age. So we have what we call a preteen track, which is 10 to 12-year-olds. Then we have a teen track, which is 13 to 18-year-olds, so high school. And then we have a young adult track, which is 18 to 25. We think it's important for that group to be, while they're adults, they're young adults. So they're in the same age, the same season of life. Because what we find is that a lot of adults, they may be 18, but if they go to a program where they're with much older peers, sometimes the issues are not as relatable. And so we have clients that come to us specifically because they want to be with 18 to 25-year-old people who are going through similar phases of life. A lot of times just graduating high school are young adults, or just graduating high school, or maybe having a hard time to graduate high school. So the 3 different programs are very different based on the ages, but actually similar in the core of what they do. So it's important because we're both clinicians, and we're kind of a small organization. It's really important to us that what's the priority is the quality of care that we provide. Our leadership team is small but mighty. And we're very involved in actually every single client that comes through our doors and until they leave. And so what that looks like is that, we usually identify up front if somebody needs IOP, first of all. So a lot of times it's us speaking with many of you, whether it's at hospitals or therapists, psychiatrists in our area, identifying that someone might need a higher level of care. And so the initial process for us is that we talk with the parents or professional. So if there's a professional who's referring, we try to get as much information up front because we don't want to waste anybody's time or resources. If we can't help, we feel really strong, and this is why we're so excited about Amy's platform, because we feel really strongly that if we're not the best fit, we want to help people get guidance to get to where they should be. But we kind of stay in our lane. You know, we do what we do. We feel that we do it really well. And so a big part of that is upfront trying to understand what are the needs of this child or young adult. So the initial call usually is from the parents trying to understand, or the professional trying to understand why they're seeking IOP. And then we usually, before we do anything in terms of moving forward, we try to understand the insurance piece. So we are in network with a number of providers, and we pull their VOB, and we try to understand what is that going to look like for the family, and we communicate that up front. And so we are in network with Blue Cross, Carillon, Kaiser, HealthNet, ComPsych, and we're actually working on in the new year also being in network with Blue Shield. So we're really proud and happy to be able to provide covered care. And if a family doesn't have one of these, or you know how it is, you pull a VOB and there's a carve out and we're not actually covered. We want the family to know that first. And then if there's a way that they can access our care that feels appropriate, then we go to the clinicals. And one of our clinicians meets with the child and the family for an intake assessment. It's just our intake process. It's not a full battery assessment or neuropsych assessment. We call it an intake. And we usually meet pretty thoroughly for about 1 to 2 hours with families to really get a good understanding about what's happening and the level of care, the level of severity. We check about risk, level of risk as well. And then we share with them what to expect for our program. Each program is a little different, and I'll go through those just for your general knowledge. But it's really important to us that upfront, that families know what they're signing up for and committing to, and that they're able to commit to the care, because of course we know that then it's going to be more effective for them if they are on board with the process. So just a little sense for you guys, I'll start with the preteen track. The preteen IOP is probably our most robust program because of the age that we serve. So 10 to 12-year-olds, we believe need a lot of parent involvement for their care to be sufficient. And both Blake and I have a pretty strong background in working with young children and their families. And so we've integrated that in how we've developed our preteen IOP. And by that, I mean, it includes, of course, the standard CBT, DBT, goals group process, kind of what you would expect is your standard. And every day there's at least one experiential art or play therapy as well, to really target to that younger population, that we can still teach the skills, but through modality that's a little more accessible based on development, as well as like I said, strong parent involvement. So parents are actually required to come to the preteen IOP with their child every day, the last part of the program. And the reason is because we have the kids, they just learned 2 skills a day, and they're required to teach their parents a skill. And the parents come to the group at the end and get taught by their kids what they just learned. Obviously, the therapists are there to teach it, but we really want to encourage the kids to be champions for their own skills. And yeah, go ahead, please.
I have a question about that. When I'm talking to parents about your program, their requirement is for the preteen program, is it 5 days a week?
So thanks for clarifying. This was one of the visuals that I had on my slide. So it's actually, the preteen program is, bless you, is 3 days a week. Monday, Wednesday, and Friday. And it's from 3:30 to 6:30. All of this is on our website. And they're required to come from 6 to 6:30.
Okay.
And anyway, they're coming to pick up their children, right? So we're just saying, come earlier, learn some skills, be involved. And then in addition to that window that I just described of time, they also have family therapy with a family therapist, an experienced family therapist that specializes in family therapy. That's scheduled in addition once a week, 1 hour a week. And in addition to that, they're required to do a reflective parenting group. And that is an attachment-based curriculum that's DMH approved, and it's 10 weeks. And so we commit to the family for the full 10 weeks for them to participate and learn these skills that are, again, based in attachment theory and be hopefully practiced at home and discussed in family therapy. And then on top of that, the preteen track is also, those parents are also required to come to our virtual parent support group, which is on Tuesdays. So if you do the math, that's a lot of commitment from parents. And we feel we feel strongly that that's the way that we can get change when kids are that young and this severe in their need. So then I'm going to kind of just give you an overview, and then anyone can ask any questions about any of the programs. But the teen program is much of the same basis that the preteen program has, but understandably, based on developmental age, has a little less parent involvement, right? So parents are not coming into the end of every group, but they are required to do the parent support group as well as family therapy. And they can add on the reflective parenting group should they choose to. Many families do choose to because it has just been so helpful for others. So the teen IOP is run from 4 to 7, Monday through Thursday. And so it's 4 days a week. But the way we do it is that we watch how treatment is going. We look at treatment goals every single week. And when treatment goals are being met, we actually drop the Thursday. And then they only come 3 days a week, Monday, Tuesday, and Wednesday. And our hope, really our work is to get people to not need IOP and to be stable enough that they can, go back to school, go back to after school activities, whatever it is that they're doing from 4 to 7, other than needing to come to IOP, hopefully. And so we do that by really staying really tightly knit to the goals. And every week there's a goals group where we hold accountability and we say, okay, how did you do on your goals from last week? What skills from group did you use? What barriers were they? Were in your way? And then what do you anticipate would be the barriers for the skills you want to use this week? And so we're really watching that closely so that we can make sure that there's movement in treatment. Parents are required to come to family therapy outside of those hours I just named. The family therapy is scheduled with the family therapist, just based on the family schedule, as well as, like I said, the parent group. And then we work very, very closely also in collaboration with all of their schools, psychiatrists, of course, parents, anyone else that, pediatricians, anyone else that's part of the care team. If they're coming from a hospital, we're wanting to be in communication if possible. The more information we know, the better we can treat, but also we like to share information that we have so that providers can continue the work that we've started on the other end or parallel. Something that's pretty unique about our IOP is that we actually encourage clients to stay with their therapist that they have if they have a therapist, because we feel that the continuity of care is best served that way. If somebody doesn't have an individual therapist, we work pretty hard to help them get one and get connected to somebody who they can see long term. That it doesn't have to be, temporary. We want it to be a long-term solution and part of the discharge plan. Lastly, I'll share about the young adult track. Is very similar to the teen track, except that it's at a different time. It's 1 o'clock to 4 o'clock, because these kids are not in high school anymore usually, and if they are still in high school, they're like seniors, and so their schedule's a little different. But mostly, we want young adults to be able to be in the workforce, and so we made the hours 1 to 4 so they could have a morning shift or an afternoon shift. But to be honest, many of our young adults don't come in with a standing job. That's part of the profile of someone who's in our IOP, that they can't hold a job, or their anxiety is getting in the way of going to school. And so our hope is by the end that they can replace the time of IOP with a job or with the school schedule, or functioning levels of activity that isn't IOP. And they are required to do family therapy as well, but they can choose who their family is. Meaning, if they're not living at home, but they're living with a partner, or they're living with some roommates, and they feel that the roommates would be part of their treatment and part of their treatment plan to get out of IOP and safety concerns, then we welcome that. But there's more flexibility there once they turn 18 to choose who the quote family therapy includes. But it is a part of our program that we do require, and we're upfront about that as well. And that's because if someone is in crisis, we need to and want to bring a support system around them so that there's tools that are being used after hours when they're not at IOP.
I love that.
I think people usually ask me about, the average length of stay tends to be about 30 treatment days. Oh, hi, Jess. Jessica is our clinical director. She just came from an intake meeting right now, which I was just going to share a little bit about, or maybe she can, but I see a hand up. So I think that might be a question. So maybe I'll pause and see if Gerald, do you have a question for us?
Yes. Do you guys treat substance use?
We are primary mental health, so we treat depression and anxiety. We don't directly treat substance abuse. A lot of times we're ruling out if there's some substance use. We're working really closely with all providers. If it's substance abuse and they need that treatment, we refer out. And that's another place where Amy comes in handy, so that she can help us make sure that people get where they need to be. Because we're not doing any kind of focus on 12-step or recovery. So a good fit for us would be someone who maybe is already in recovery, maybe has a history, but that's not a current presenting problem.
Yeah. Well, although the work you're doing could still help with substance use, because you could be getting to the root causes of the substance use.
Exactly. And we often do. And so that's why it's kind of a challenging question to answer, because it depends on, sometimes there's some, if we meet with them at the initial intake and they say, yes, I smoke or I drink, but I can put that on pause while I'm in treatment, then obviously it's not a problem in their life. It's not crossing over to abuse. It's just use. We absolutely can get to the root of why it's, maybe a negative coping skill, but it's a coping skill, right? We can replace those coping skills with different ones. Then we absolutely can work with them. But if it's someone who they really need a focus, we're just not going to be enough. We're not going to be focused on that enough. And so we wouldn't want to shortchange anybody. We would want them to get the care they need, and then they can come back for, more generalized care. But it really would be case by case in that way. Jessica, would you add anything to what I just said? I think I just kind of said it really generally.
No, I think you said it perfectly. I mean, a lot of times clients who have substance use will go and get treatment for that, and then they'll come back to us and get mental health support. And typically they have like a 12-step program they're involved in, or a recovery coach or a therapist specializing in that. So it's not to say that if a client has an addiction, we can't treat them. It's just a matter of treating what's more imminent first, which would be the substance use, and then having them come back to us.
Understandable. Thank you.
Maybe I should pause and see if there's any other questions before I go on.
No, I'll throw this in there as well, Gerald, and for anyone else who had a similar question about that. We do have programs in the RecoverWell marketplace. Hannah is on the call as well. She works at Centered Health, and they have a couple of teen programs that do include on the residential level. They do address substance abuse and chemical dependency as part of their programming. One thing I've seen frequently with IOP with every age group is that it also is about a little bit about what's accessible physically. LA, we're always worried about traffic and making sure people can be reliable to their treatment. So knowing that we can get people to engage treatment, the organization not to engage in conversation is like being clear about where they are. So if they're stepping down from a residential program, having them understand geographically where the outpatient is and making sure that they can really commit to that. And I'm sure that's part of your conversation with them too when you're talking about the commitment.
Definitely. Yeah. And so that brings up another point is that we're fully in person, and we have been, the whole time. So while we do have one support group that's for parents that's virtual, everything else is in person and required. So that is a conversation that happens if a family lives far. We want to make sure that it's accessible, that they can make it here and engage fully in their treatment. No pun intended. And then that intake, so we take quite the intake process, I think, pretty seriously, so that we can make sure that once we get started, we know that we can actually help, and that we do. And we're watching that really closely, like I said, through the treatment plans. And we also are watching, we're taking PHQ-9 and GAD-7s as a way to monitor the severity throughout treatment. And then we're really pretty focused on discharge planning. I would say from the beginning, actually. And that's because like I said before, we want to make sure that people can be set up for long-term care, not need to return back to this level of care if we have everything set up, ideally. Of course, things happen, but we want to set people up for success. And what that looks like a lot of times is really understanding outpatient care and what the needs may be afterwards. So I guess I'll open it up. I just got a notification. We have 5 minutes. So I'll open it up.
We always go over. So I'll just, in a few minutes, we'll do our raffle. And then if people want to stay on and ask more questions, I always like to leave it open for as long as people need to get their questions answered.
Awesome. So let me just say one thing is we have a couple of areas of specialty that I think might be important to add. I already mentioned suicidal ideation, self-injurious behavior, anxiety. A lot of times school refusal shows up in those presentations, as well as gender dysphoria and LGBTQIA. We have a specialty group for LGBTQIA. It's not an IOP group, it's an outpatient group, but it's sort of just a support group that came from a need because a lot of our clients were needing a place to be and get support, as well as preteen IOP, is a little bit of an area of specialty for us, a little bit different than I think kind of what's out there. And we feel really strongly about the intention that has been put into our preteen track.
I want to share quickly too that the way that I had actually originally met with Adelina and Blake was I had a patient that was very, very young, 8th grade. I don't remember the age of this young person who was going through a gender transition, was actually starting their transition. And we discussed at length their program, and I was really excited about this program. It was not going to work out for this person because of the distance, but Adelina was super helpful in talking to the mom and making sure that we had some resources for this patient and some community resources for the family as well, which I found to be so helpful. And this, at the end, the goal for everyone on this call is always to make sure that people are getting to the right place at the right time. And so I'm grateful that Adelina was able to jump on with the mom and be helpful with that process. And it wasn't just about, we want all patients at our program. It was more of, we want this patient to get what they need to make a successful transition, and have the parents and the family really support them in that. So that was great. And in that conversation, I learned a lot about how they segment their groups out, not just by the age, but for those very specific concerns that a patient might be having, whether it's suicide ideation or self-harm, having gender dysphoria, all of these things. And it's such a vulnerable population. So I want to make sure that everybody knows that this program is there and that you can also give them a call if it's not going to be the right fit. You'll see on Recover Well, when you put the patients in, if Engage doesn't pop up, I think it's worth a call in to sort of see what their opinion is on a patient because of that, because they know more. I'm a logistics person. I'm making sure that the connections are made. These are clinical experts. So, Adelina, what's the best number for them to call for inquiries if they're not really sure, or they just want to reach out and find out, get some advice from your team? What's the best number?
Yeah, so it's the main number, and they would get probably in touch with Jennifer Cuccia, who can absolutely talk through the basics with them. So the main number is 805-497-0605. And really, like I said, we're a pretty small team. So whoever you get to can get you to the right person. And we're all thank you for putting in the chat. We're also all pretty willing to spend time, myself included, Jessica, Jen. We're all willing to just spend time helping families the best way we can.
I have two questions as well then. One question is, in terms of, if you said it's the preteen is a 10-week program.
So the parent group, the reflective parenting group, is a 10-week program.
Okay.
And we commit to the parents. So let's say the kid is in our program and the 10 weeks haven't been completed before they discharge the program. We still are committed to the parents completing those 10 weeks. That's just what we feel is the right thing to do. So we do that. But sometimes kids are here longer than 10 weeks, and sometimes they're here less than 10 weeks. It really just depends on their treatment plan and how they're doing and the severity of their symptoms. It doesn't mean that they have to be here for their parent to continue the learning that they're doing. And something else I want to mention is that all three tracks, what separates them is not just the time and the days, it's also the therapists. We have, it's staffed differently, and they don't overlap each other. So the teens are not with the preteens, and the preteens are not with the young adults. They are really on their own. And I think that's important for parents to feel comfortable and safe.
And once they complete the program, the parents and the student and the patient, is there an option to continue one-to-one with your clinicians for routine therapy?
Yes, there is. So that's a little bit unique as well, that we do outpatient work. All of our clinicians do outpatient work as well. The only thing that's different is that with IOP, we are in network with a number of providers, and for that individual work, we're not in network with those. So that's why it has to fit long term, because we wouldn't want to set somebody up for it to not be something they can sustain long term. And so if they need, they're seeking to get individual therapy through their insurance, we help them with that, and we guide them, because we do collaborate with a lot of providers in our area. So we can say, this provider has this insurance, maybe call them, and we do that work. But a lot of times they're connected to their therapist that they meet here, and that's totally fine. It's just that we're upfront about the insurance piece. That does change sometimes, the accessibility.
Okay, I lied. Two more questions. I think the more important question, in case we run out of time, is a lot of patients that we see that are in school years have been diagnosed with spectrum disorders. Do you work with patients with spectrum disorders?
Yes, we do. I wouldn't say our programs are targeted towards working with kids on the spectrum, but we do a lot of social skills, and it's definitely, I would say it's like 99% of our population falls somewhere on the spectrum, diagnosed or not. There have been a few cases that if it's too severe and our groups require something of them that is triggering or it's not working for them, then we would discuss that and we would help them and guide them. But in general, it's not a problem and actually pretty common.
Okay, and then my final question is back to the location issue. If a patient and their family decide that this is something that they want to start and address, like during a school break, for example, like a summer break or something like that, is there longer term housing options nearby? Like, are there any hotels that you recommend where they have like extended stay or anything like that?
Yes. Well, I would honestly, that would be something I would probably work with you on because I feel like you would know a lot of resources. Yes, there's local hotels and extended stays, but we haven't worked with that a lot because truly we tend to serve our community, our immediate community. And we have had people that have driven from, Ojai, Torrance, Santa Clarita, definitely. I just haven't had someone stay locally like that. So we could work with them. But I don't have anyone off the top of my mind that's like, this would be the resource or the recommendation.
Oh, okay. Well, we'll work on that. So, if you're a little bit further out from where they are, we can try to work on some options for that as well, if this is the best resource for them. So, I'm gonna quickly do our raffle because it's fun and it's Friday. Let's do that. And then if anybody wants to stay on and ask questions, can you guys see my screen?
Yeah.
Okay, wait, but it's not showing. I don't see what's behind. Now I have the same issue that you you have.
So, all right.
Okay, so let's go. Here we go. Oh, that's my other. There we go. So I'm gonna spin it, and then if the person's not here, we'll keep going. Hopefully this doesn't go crazy. Come on,
So
baby. Tanya, I saw her on here. Are you on, Tanya? I think she is.
Yeah.
Hi,
Amy.
All right, Tanya, I will send you your Amazon gift card. And just a reminder, we have a couple more before the holidays where we're going to do the same gift card drawing. And everybody, please join us for that. We're going to meet with Hillcrest on Wednesday. That's another teen residential program. I'm super excited to tell you about them. And then on Tuesday, we're going to meet with Recovery Beach. They just got in network with Medi-Cal, so it's a great resource for Medi-Cal patients. Yeah, huge. They've been working on it for a couple of years. So, and I know a lot of our patients have Medi-Cal. So
yes,
please
that's
join
awesome.
us with those. Yeah.
So,
And
Amy, I have one question real quick.
yeah, go for it.
Hey, Adelina, I heard you say you guys have a contract with Carolyn.
Yeah.
So does that mean you accept Medi-Cal through?
No, that's the little annoying part. No, Medi-Cal
Okay,
is the non-Medi-Cal. Yeah.
It's their commercial. It's not the Gold Coast Medi-Cal.
Yes.
Got it.
Thanks for your question. And I think Gerald also had his hand up. I saw John's as well.
Oh, yes, it was on location. So I'm in Northern California and you guys are in Southern California. So I was wondering, did you have like a special referral? Like if you was to refer someone that's in the San Francisco Bay Area, do you have a comparable or like a go-to special place you would refer to in this area?
I would say it would really depend on what the case is and what the needs are of that particular child or family. because I think that we do have a couple of people that we work with up north. It just really depends on what we're looking at. Someone exactly like ours, I don't know, because I think we, I'm very focused on what our program is and how it goes, because I am intimately involved with it, but it's hard to say about other programs.
Yeah. And Amy, if I was to go to Recovery Well, I would just kind of do a teen IOP search. Is that best
Yeah.
way to do that?
You would enter the patient's information, and the technology has a logic in it that's going to match you. So that's another piece that's going to make it a little bit easier for you to know if it's a pretty good fit for Engage. There are nuances that isn't going to catch,
I
but
know, that's why I said earlier.
insurance is one of the pieces that we're going to
They just ignoring me, so I'm like, I'll come back after you're done.
That's not me, I promise.
Artie, you got us on your speaker.
Oh, sorry.
That's okay. So the platform is going to rule out programs that aren't going to be a good insurance fit. And we do have, Gerald, a program that's statewide that does one-to-one telehealth and one-to-one outpatient therapy for youth with Medi-Cal insurance for the entire state. So if you need that resource, you can reach out to me directly, or you can put the patient in the system and they'll automatically match to that. But everybody take my phone number down. So if you need help with, getting the system, or if you need help getting directly in touch with any of the programs that we work with, just shoot me a text and I'll happily directly connect you so you can ask and they can answer all the questions that you have.
Thank you.
Yes, Amy has been amazing in helping us connect families with services that, we have no idea exist. And that's why this is so exciting. So thank you, Amy, for putting this together and for connecting all of us, as well as the families that need help.
Thank you so much. I really look forward to this time with everybody, and I appreciate it on a Friday afternoon. So hopefully we'll see you all on Tuesday and Wednesday of next week before we all sign off for Hanukkah and Christmas.
Sounds good. Thank you so much.
Bye.
Bye.